This is the clinical case of our consultancy as a consequence of a COVID pandemic. It's 55-year-old. It's referred to nephrology clinic. And this is the history. This is the comorbidity of obesity, type 2 diabetes, hypertension, hyperlipidemia. He had a recent weight gain of 10 pounds after he started working from home. This is his medication, the physical examination with the body mass index is 42, and blood pressure is there. This is the GFR of this patient is with chronic kidney disease, 45 milliliters per minute, and this is his proteinuria. And the question for the audience is, with this patient, what therapeutic strategies would you consider to treat obesity in patients with CKD? Okay, we try to answer this question. As you know, the obesity play a role and an influence in different organ damage, but we focus your attention in the kidney disease. And this is the histologic changes and the hemodynamic effects of the obesity. So this is the normal glomerular, and this is the influence of different mechanisms, etiologic mechanisms, the hemodynamic, hormones, lipotoxicity, and this is the final result of this glomerular, is glomerulomegalia, the increase of the diameter of this glomerular, and finally is this lesion, a typical lesion of this glomerular. As you know, the relationship between obesity and renal damage, this is some reviews. This is recently, I can recommend it, this review of our department, which is patients with obesity and what is the risk of renal disease. The first question is, how much percent of patients with CKD have obesity? This is an study, an American study. It's a registry of a study. It's a famous registration of the patient. And you can see that the 44% of a patient with CKD have obesity. This is a most important and significant value. And other epidemiological study relate the influence of obesity and the GFR. You can see in this conclusion of this study with an important number of healthy individuals, more than 5 million. There is a close relationship between obesity and increase of risk of GFR decline and mortality in patients with or without CKD. But before to talk about the different options of the therapeutics options in obesity with the CKD, I would like to talk about some gaps related to obesity and the management in CKD. Because, as you know, there are a little information in patients with CKD and obesity. No, the obesity relation with CKD. What is the link in the pathways on obesity and CKD? This is a very good question to research in the future. Or what is the relationship between weight loss and renoprotection? Or other things, would you compare the renoprotective effects of very weight loss strategy? These are the questions of the future, and we try to answer this situation. As you know, the objective of obesity patient is weight loss, and weight loss with different techniques, so metabolic surgery or diet or drugs, or try to reduction of the proteinuria, because proteinuria was a biomarker of a progression of GFR of CKD of this patient. But you know that there are a lot of guidelines of managing of obesity. But the problem is no at-risk patient with CKD. This is the most important question. The first option was the lifestyle factor, diet or physical activity. After we are talking, Esteban, about the physical activity. But there are some different studies, but so what is the role of the lifestyle with the weight loss in patients with CKD? We comment only 3. This study is our group 20 years ago when it was young, or younger than now. And this is a very nice study because only select 30 patients and randomized to 2 types of diet, or low-caloric diet or normal diet. And you can see that a moderate weight loss induced an important decrease of proteinuria in these patients during only 5 months. This is a very good news for our patients. And this is the close relationship between weight loss and decrease of proteinuria. In this other study, there are other questions. What type of diet is best to our GFAR? In this study, it included more than 300 patients, 100 patients with chronic kidney disease, 3 types: low carbohydrate diet, or Mediterranean diet, or low-fat diet. And the conclusion of this study is the same effects of the GFAR in patients with or without CKD. It's the same. The most important was the weight loss. Another question is, this is an important study. Look ahead, this trial with a lot of number of patients, and with these patients with the GFAR below to 60 milliliters per minute and with proteinuria. And the conclusion of this study was very important because it's a too long follow-up, more than 9 years, and reduction of weight loss was in the intensive R with diet and exercise, and we conclude that it's possible to reduce the risk 30% in very high risk KDIGO guidelines with the CKD. And finally, this is a Spanish study with a collaboration, a lot of centers. With this the Mediterranean diet. We recommend this diet, it's very good diet. And what is the influence of this diet in 2 types of patients with the relation with the CKD progression. And the conclusion again in this study that this kind of Mediterranean diet would preserve the renal function and delay the CKD progression in this patient. But this is other option in our patients. The second point was what is the information on the obesity medications. This is the FDA approved this medication, and you can see the focus in this kind of drugs, GLP-1 receptor agonists. But the problem is the majority of these drugs were eliminated by urine. And for this reason, the patients with CKD are often excluded for randomized clinical trial. This is a limit of our patients with CKD because the majority of studies were excluded our patients. And you can see in this, and I recommend it to read this consensus. It's very important. Some of these authors is here today. And I think it's very important because the conclusion is what is the role of SGLT2 inhibitors or GLP-1 with a nephroprotection, a cardioprotection with patients with CKD. And I think I recommend to read this consensus. I know that tomorrow there are 2 talks about this question, but only some words about this. This is the effects of GLP-1 and the hemodynamic effect, decrease of GFAR, hyperfiltration, and decrease of albuminuria. This is nephroprotection. And SGLT2 improve hypertension, podocyte, obesity, inflammation, fibrosis. We have a very good news for our patients with 2 new drugs. This is an example to use. This is a leader study, and I recommend because these are the number of patients, 229 people with CKD stage 4, and it's very safe to use this drug in patients with CKD, and we saw that the effects or the beneficial effects of the patient was similar in patients with and without CKD. And this is the evolution, or this is the future, is the combination of two drugs, DLP-1 and SLG2. And the problem is, again, no information about what happened with the CKD patients. And I think it's very important to research this or investigate about this point. Okay, we know that there is the influence of renin, angiotensin, aldosterone, and our obesity patients have hyperaldosterone secondary to obesity. What is the role of different drugs? This is different studies of our department. We can use randomized 3 possibilities: OAS inhibitors, cis inhibitors A or B, or mineralocorticoids receptor antagonists. And you can see that the effects of the reduction of proteinuria was higher with this finerenone versus AC inhibitors. This is a good possibility to use in our patients with proteinuria and obesity or chronic nephropathy proteinuric disease. Or it's very cheap to use spironolactone. Nobody wants to do a trial with this drug because it's very cheap. But this, if you use 25 milligrams added to the usual treatment, it's possible in 48 months to reduce the proteinuria near to 60% in this patient. This is other possibility to use in our patients and use in this occasion. Or recently, this is a nice study with other kind of mineralocorticoid receptor agonist, finerenone, and this is the effects of the cardiovascular and the progression of CKD. And this is the benefits of the use in this kind of patients with diabetes and chronic kidney disease. A percent or high percent of this patient has obesity in this occasion. Okay, but what is the role of bariatric? I prefer to say metabolic surgery. What is the role in different etiopathiogenic mechanism or relation with the adiposity, glomerular hyperfiltration, and other situations. I think it's probably in the future we use which patients could be the benefit of this bariatric or metabolic surgery. If we have, for example, new biomarkers such as TNF, and in diabetes, it's possible to select the patients who develop CKD. Or, for example, in which state we decided to do the bariatric surgery. It's other information, and in this nice study, you can see that the high or moderate risks is possible to cold chain to other CKD stage. For this reason, the answer of this question, when, is early, because we have the benefits of this. The problem is when you try to investigate about how many studies are there about obesity and CKD and bariatric surgery, there is a little information. For this reason, this is the most important, for me, in my opinion, this study in relationship the bariatric surgery and the GFAR. What happened with the GFAR in the patients with obesity and CKD. And in this occasion, in this study, you can see in both graphic, this is the possibility of reduce the risk factor of decline of GFAR or end-stage renal disease metabolic surgery versus control patients. For this reason, I don't know, many years ago, 5-6 years ago, we decided to do this exciting study, but the problem is now is published in the CKE journal, and this is the title of this study: Renoprotective Role of Bariatric Surgery in Patients with Established Chronic Kidney Disease. This is the study design. We use the patient with a control themselves during 6 months after bariatric surgery, follow-up during 24 months. This is the inclusion criterion. The problem of this criterion was the selection of the recruitment of patients, because it was very, we need an amount of proteinuria in this patient with a GFR. And we tried to study different questions: renal parameters, inflammatory, adiposity, cytokines, and other questions. This is the selection of the patient. Was very, very difficult. I talked with Esteban and say it's impossible to find patients with GFR and proteinuria higher than 1 gram per day in this kind of patient. And finally, only 12 patients. This is the baseline of these characteristics of this patient, and you can see the majority of the patient was diabetes, hypertension. We talk about a fatty liver. Fatty liver is an important role in obesity and diabetes. We have published now in an NDT journal what is the relation with the fibrosis and a fatty liver and the evolution of diabetes. And we saw it that is very important because it's the most important risk factor to decline of GFR, most than proteinuria. This is a good point to research in the next years. And this is the medication. The majority of patients receive RAS inhibitors. The majority of patients underwent this bariatric surgery, gastric bypass. Only 2 patients with this gastrectomy. And the first question is, what is the role of this renin-angiotensin-aldosterone system? What is the role of aldosterone? Because you know that is very important in the damage. You can see in this table what is the effects of bariatric surgery in the weight and the blood pressure. And the blood pressure, you can see the majority of patients with hypertension and decrease the number of patients with hypertension in the number of prescription of the drugs of this patient. And you can see the decrease of renin and aldosterone in this majority of the patient. You can see what happened with the weight loss of this patient. This is an example of a patient with this body densitometry, and you can see the decrease of fat and lean during 2 years. This is the result baseline at the end of the study, and decrease an important body fat percent of this patient. The second question was, what happened with the hyperfiltration or the hemodynamic effects in this kind of patient? As you know, that what is the influence of hemodynamic effects? This morning, Sergio, this is a very nice paper of a Canarian group, and demonstrate it's very important to have a gold standard method to measure the renal function in this kind of patient, because underestimated the GFR in this patient with obesity, and the usual MDRD or CKD-EPI is useful to measure the GFR in this patient. And so the results, I think, is for me, it's the most important result of this study, because you can see what happened with the estimate GFR of this patient. The majority of patients after the bariatric surgery was increase GFR or maintain the GFR. But look at this area after bariatric surgery. 2 questions: is the decline of GFR of in this majority of patients? This is the hyperfiltration. as you know, what is the effect of weight loss. But the second question is, what happened with the patient with below GFR 60 and decline of GFR? We wanted to know, or we wanted to say, this is relative hyperfiltration, because this patient is possible to reduce or to decline the GFR with patient with CKD. And this is an important result of this study. And you can see in this table the GFR and the proteinuria. The proteinuria, as you know, that the reduction with the weight loss, these numbers is higher than 50% at the end of the study. But the most important data was, you can see what happened with these techniques. We can use ioxol in these patients. We can see that is decline of after bariatric surgery of GFR. At the end of the study, increase the GFR, but it's totally different what happened with the measure GFR. It's totally different after bariatric surgery, and this is an important point to study. Okay, we are talking about the proteinuria, but proteinuria is a late biomarker. We need to study probably other biomarker like a podocyturia or podocyte in urine is possible to study in this patient. This is an example of our patients with the control. And you can see the amount of podocyte in the urine of our patient. What the rule about adiposity or the adipose tissue is, as you know, the insulin resistance, oxidative stress, inflammation, RAS activation. This is the different mechanism in this patient. And you can see what happened with the control of diabetes. The majority of patients, the diabetes discontinued, and the patient received insulin, antidiabetics, for the control of this situation. And what is the profile of the lipids? This is the parameters of this study, and you can see the C-peptide, insulin, or glucagon decrease significantly after bariatric surgery, or the insulin resistance after bariatric surgery. This is a very important point to know in our obesity patient with CKD. But what happened with the adipocyte cytokines was the same. You can see the leptin, bisphosphine, adipsin decrease significantly after bariatric surgery. And by the way, adiponectin increase after the bariatric surgery. As you know, that this is the effects of cytokine adipocytes. But other question for me was important, together with the GFR decline, what happened with the lipids on this patient, and this is lipidomic, and you can see what happened with the triglycerides. This is the patient's pre-bariatric surgery or before the bariatric surgery, and what happened with the triglycerides after the bariatric surgery. It's the most important point, disappear and reduce the proteinuria. The hypothesis is, what is the role of these hypertriglycerides in the renal function? We are investigating in the future years about this theme. The last 2 words about the inflammation, because as you know that in obesity, there are many mechanisms of inflammation that influence to develop CKD. What happened with the pro-inflammatory cytokines? Decrease after the bariatric surgery, interleukin-1 or 6 or TNF, alpha or MCP-1, decrease after the bariatric surgery. And in other factors, like such as vascular endothelial growth factor or T transforming growth factor BT1, BT2, decrease after the bariatric surgery. This is the stop the fibrosis of our patients after the bariatric surgery of weight loss. and this is other most important point, and this is the close relation between fold change in proteinuria and fold change in interleukin-1 or vascular endothelial growth factor. It's the close relation between two parameters. Okay, so conclude this study. If we can use all parameters together, the renal parameters, glucose, lipids, inflammatory, and other parameters. This is our patients before the bariatric surgery. A lot of red of our patient, but this is a heat map after the bariatric surgery. Is changed to green and to recover the normal situation of this patient. So conclude, this is the most important renal-protective effects of the bariatric surgery effects, metabolic effects, and antihypertensive effects. And this is the probably algorithm can be used with the obese patients with CKD, and you can see the different class of obesity. Lifestyle with drugs is the first possibility or the first step of our patients, but after we consider the bariatric surgery or metabolic surgery to reduce the weight, reduce the weight to find these results such as a study. And finally, this is my acknowledgement. This is a multidisciplinary study. This study was possible thanks to surgery, Department of Surgery of my hospital, endocrinology, nephrology, Esteban and other colleagues, and Gemma Medina in Alcorcón, because it's very important to study the lipidomic in this patient. Thank you very much for your attention and questions.
Well, thank you very much, Enrique, for this comprehensive view of a difficult problem. Are there questions from the audience? Oh, yes.
Thank you for a very nice talk. It's amazing how these operations benefit many patients suffering from metabolic illness. So in Denmark and many other countries, there are quite stringent criteria for who we can refer to metabolic surgery. Usually it's BMI above 50, or in other cases BMI above 35 with comorbidities. In Denmark, CKD is not one of those comorbidities. It's arthrosis, it's sleep apnea, it's PCOS in women, and diabetes and hypertension. Should CKD be one of the comorbidities that allows you to refer patients with BMI just above 35 to bariatric surgery?
At first, when we did this study, we performed this study, we have a problem with the surgery department because they don't want to do the surgery in this kind of patient with CKD because they talk about the complication after bariatric surgery. But after this study, we consider that it's possible to use the BMI lower than 35, included in this patient, because the CKD is an important comorbidity in these patients. If you have a patient with a CKD and unhealth metabolic disease, is it possible to improve this patient? Because we have, for example, in this clinical study, we did a renal biopsy in one patient because don't improve the proteinuria. And we find the diabetic renal disease. And the conclusion of our colleagues was, what is the point of return to the increased GFR or improve of CKD. For this reason, I think it's important to be early to say, okay, we need to with this patient the possibility of metabolic surgery before to this condition, because only 35 is a number, but we consider other comorbidities in this kind of patient. You could consider the metabolic surgery. For me, I think it's earlier than 35. It's possible with the 30 or 25 in other patients with a lot of comorbidities.
Thank you very much, Enrique.
Thank you for a very nice talk. In the cardiovascular field, they have had trials now where they try to reduce the risk with anti-inflammatory drugs, such as canakinumab. Do you think they would also have effect on renal function?
I don't know now information in this kind of patient, but probably this is other possibility to use in. We think the most important is the weight loss. The weight loss with different options, so the metabolic surgery, lifestyle, exercise, or different drugs. It's possible in the future the multi-target therapy, because you can use diet with this first step, or medication, or bariatric surgery. But never think about what happen with the patient with consider, for example, lifestyle, with exercise, and finally decided to include drugs, or decided in patients with main comorbidity, early the bariatric surgery in this kind of patient. This is other possibility, but I think the anti-inflammatory we saw with the pro-inflammatory biomarkers and decrease after the bariatric surgery, but I think it's the same result with the weight loss with other techniques.